Hello and welcome to Clinical Cases. Today we're going to be looking at the musculoskeletal block part 2, and this will involve us taking a look at some common musculoskeletal conditions including osteoporosis, osteomalacia and Rickets, Bechets Disease, avascular necrosis, systemic vasculitis and the different forms of that including temporal arteritis and Bechets Disease, and then we'll finish by taking a look at Duchenne muscular dystrophy and cerebral palsy. So let's start by looking at osteoporosis, which in layman terms means porous bone. So it's defined as low bone mass, and we can see the microarchitectural changes here. So there's deterioration of bone tissue, and as a result the osteoporotic bone has enhanced bone fragility and an increased risk of fracture. Often there's no symptoms of osteoporosis until the first sign being a fracture. This is most commonly in females over the age of 50 because they've got a 50% increased risk of fragility, so they've got an increased risk of fracture, and therefore at this fracture time the investigations will reveal that they have osteoporosis. So remember that bone changes as you age, and the amount of bone tissue naturally starts to decrease after the age of 35. So it's constantly increasing up until about 20, 21, and then it starts to decrease after the age of 35. And this is described as bone loss. So bone thinning is much more significant in later life, which explains why osteoporosis and broken bones become much more common in older age. So the risk factors for osteoporosis can be remembered by access, so alcohol, corticosteroids, calcium levels low, estrogen low levels, smoking and sedentary lifestyle. So really all of these start to point towards older people. So they typically are no symptoms in the early stages, as we've said, of osteoporosis, but there can be back pain, there can be loss of height over time, and kyphosis and lordosis may predict osteoporosis before it's discovered clinically. In terms of treatment, we can use bisphosphonates and denosumab, so anti-resorptive medications. Also anabolic medications and hormones such as estrogen can play a role in prevention and treatment of osteoporosis. So next we look at osteomalacia and Rickets, which essentially is the same condition. It's softening of the bone due to defective mineralization of newly formed bone. So this can either be in a mature adult skeleton where you have osteomalacia, or it can be in a developing skeleton of a child, and therefore it's called Rickets. Essentially the cause behind this is vitamin D deficiency normally, so this is common in the elderly when they're housebound, some ethnic groups as well, or intestinal malabsorption of vitamin D. And it can also occur as a result of abnormal metabolism of vitamin D, so for example liver or renal disease or drugs such as anticonvulsants can also cause osteomalacia or Rickets. The clinical presentation of this usually will be bone pain, bone tenderness, fractures, muscular weakness, malaise and tetany. Remember, patients won't have all of these, but a few of these may indicate osteomalacia and indicate to do further tests. So you'd look at biochemistry, you'd look to see if there's low calcium, low phosphate and raised ALP. And remember, calcium and phosphate levels are really closely linked with vitamin D levels. So going back to your anatomy and physiology, be aware of that. And there's really hypocalcemia and hypophosphatemia in advanced stages of osteomalacia. So low 25-OHD and raised PTH will also be a clinical investigation sign, and doing a bone biopsy is the gold standard for diagnosis of osteomalacia. So there are ways to prevent this, including eating a diet that's got an adequate amount of calcium, phosphorus and vitamin D in, and people with kidney disorders should have their calcium and phosphate levels monitored regularly to ensure that they're not decreasing. So Paget's disease is a disorder of bone remodeling. So as you know, bone is constantly remodeling with osteoclasts and osteoblasts working. So osteoclasts forming bone resorption, osteoblasts creating new bone. But this is a disorder of abnormal osteoclast and osteoblast activity. And as a result, we get poor quality woven bone. And as a result, this can cause affected bones to become fragile and misshapen, and therefore an increased risk again of fractures. So Paget's disease of bone is most commonly occurs in the pelvis, the skull, the spine and the legs, and most people who have this are asymptomatic. Now normally this disease causes your body to generate new bone faster than normal, and the rapid remodeling produces bone that's softer and weaker than normal bone, and as a result this can lead to pain and deformities, and as we've already said, an increased risk of fractures. It's common in 40 plus individuals, and it's more common in men than it is in women. It's actually really quite rare in some parts of the world such as Scandinavia, China, Japan and India. And on an x-ray there are 4 signs to look for Paget's disease, so a thickened cortex of the bone, a trabecular pattern, a bone enlargement and a bowing deformity. The causes behind Paget's disease are a mix between genetics and environmental factors. So common genetic mutation is P392L, maybe a little bit too much depth for what you need to know, but environmental factors include an infection, mechanical loading of affected bone and poor nutrition during childhood. It's always important to consider a differential diagnosis here as well. So with the signs and symptoms that a patient may present with, you may be thinking about osteoporosis, osteomalacia, osteopenia, and osteotitis fibrosis cystica as well. So avascular necrosis next. This occurs when the circulation of blood is impaired to a region of bone. And as a result, when we've got this impaired circulation, we end up with death of osteocytes and other cells in the involved area. So remember, osteocytes are those precursor cells of bone. So it most commonly affects the epiphysis of long bones, and half of cases show multiple sites of damage. So anyone can be affected by avascular necrosis, but most commonly it occurs between the ages of 30 and 50, and it's often called osteonecrosis. So many people are asymptomatic with this in the early stages, and as the condition worsens, it tends to be that the affected joint hurts during weight-bearing activity. Eventually, over time, that pain will be present even during rest in severe advanced cases of avascular necrosis. Essentially, it's due to disruption of blood flow, as we've said, to the bone, and this could be through joint or bone trauma, which may damage the blood vessels. It could be due to lipid deposits in blood vessels, or it could be due to medical conditions such as sickle cell anemia, Gaucher's disease, and decreased blood flow, because these all decrease blood flow to the bone. So having said that, the majority of cases of avascular necrosis are idiopathic, and we can stage avascular necrosis using Behcet staging. There are preventative measures that we can take, such as limiting alcohol consumption and decreasing cholesterol levels, because both of these contribute to the lipid deposits in blood vessels, which would reduce the blood supply. We can also monitor steroid use, as there's also links between steroid use and the development of avascular necrosis. Commonly affected bones include the neck of the talus, the scaphoid, the head of the femur, the shoulder, hip and knee joints. And key to point out here, the scaphoid, head of femur, these are bones that have got a poor vasculature anyway. Systemic vasculitis is a very much an umbrella term, systemic vasculitides, in other words for autoimmune disorders characterized by inflammation of blood vessels. So this diagram here nicely summarizes the different types. So you can have large blood vessel vasculitis, small blood vessel and medium blood vessel vasculitis. So the ones we're really going to focus on over the next few slides are temporal arteritis, which is an example of a large blood vessel vasculitis, ANCA associated vasculitis, and then we're also going to take a look at Bechets disease as well. So just to give a brief overview of systemic vasculitis, there are complications that can ensue. So as a result of large vessel vasculitis, it can lead to blindness, stroke and claudication. Medium vessel vasculitis can lead to foot drop, wrist drop and cutaneous ulcerations. And small vessel vasculitis can lead to oxygen dependence, renal insufficiency and renal failure. So to kind of give an overview, vasculitis can affect all ages, although some types are restricted to certain age groups. And vasculitis tends to most commonly affect Caucasians, although many African Americans are affected, and pretty much anyone can be affected by the disease. So vasculitis does have a genetic component, but it's not inheritable, and it's a chronic relapsing disease, although some patients may experience prolonged remission. So just to zoom in on a few of those, first of all we take a look at ANCA-associated vasculitis. So ANCA stands for anti-neutrophil cytoplasmic antibody. So this is a type of blood vessel inflammation caused by autoantibodies. So normal antibodies circulate in the blood and fight foreign antigens in the body, as we know, but autoantibodies are abnormal antibodies that attack our own cells and tissues. And in this case, we're attacking the cytoplasm of neutrophils. This is a small vessel vasculitis. And when ANCAs attack, they cause the neutrophils to attack the walls of the small vessels in the different tissues and organs of the body, and as a result we get swelling. So another type of vasculitis, this is a large vessel vasculitis this time, is temporal arteritis, or giant cell arteritis as it's commonly called. And this is a serious condition that requires urgent treatment, because otherwise it can lead to those large vessel complications which we previously discussed, like stroke and blindness. Next we have Bechets disease. So this is a rare disorder that causes blood vessel inflammation throughout the body. So there are numerous signs and symptoms of Bechets disease, but they're all quite unrelated at first, and therefore it needs a good awareness of the condition in order to be able to diagnose it. So Bechets is a type of small vessel vasculitis, and it's associated with HLA-B51. So the clinical diagnosis here of Behcet is made on exclusion of other conditions. So other conditions you may consider are Crohn's, celiac and Sweet's disease. There are no particular lab tests which will confirm Behcet, so that's why it's important to make it clinically and exclude other conditions which it could be. So the signs and symptoms you'd see in Behcet's disease include recurrent oral ulceration, and by recurrent we mean more than 3 a year, plus 2 of the following. so recurrent genital ulceration or scarring, eye inflammation, so uveitis, skin lesions, and positive pathogy. So the pathophysiology behind this isn't particularly understood in great depth, but what we're thinking here is a normal artery is becoming inflamed and therefore narrowed. The artery may become completely occluded, leading to either an aneurysm, due to having those weak vessel walls, or death of a tissue that the blood vessel supplies. One important thing to consider with the diagnosis of Bechets is if your patient's got genital ulcers, these are normally associated with infections such as herpes simplex. Now there's quite a stigma around this in the social aspect of this condition, and obviously in Bechets these genital ulcers are not caused by infections, so it's important to provide psychological support to the patient as well, especially if they're with their partner, and to give support in that respect as well as medically managing the condition. The risk factors for Bechets are age, so most commonly affecting people in their 20s and 30s, and people from the Middle East, so Turkey and Far East as well, are more likely to develop Bechets, but not exclusively, so it is more than possible to develop Bechets, for example, if you live in the UK or America. So for treatment or management, mild cases can just be managed by treating flare-ups, and more severe cases require control of the disease constantly via steroids or immunosuppressant agents. Next we look at Duchenne muscular dystrophy, so this is progressive, generalized disease of the muscle, most often caused by defective or specifically absent glycoproteins. So in this case it's dystrophin, the protein dystrophin, which is missing from the muscle membrane. So Duchenne muscular dystrophy is the most common of the muscular dystrophies and most rapidly progressive as well. So it's X-linked recessive in its inheritance pattern and therefore mainly affects males. The only exception to this would be if a male suffers a genetic mutation such as Turner syndrome, and therefore it would affect females as well. So the symptoms and presentation of Duchenne muscular dystrophy include normal early development but then delayed walking and speech. These patients might also suffer a waddling or tiptoe gait, and there's proximal to distal weakness present. The key diagnostic sign is Gower's sign, and this is where a patient will help themselves to their feet by using their hands, and this is really worth Googling on YouTube to have a look at how this manifests in a patient. There'll also be elevated creatinine kinase levels, because creatinine kinase is what's released by damaged muscles, and a muscle biopsy to look for dystrophin is really important as well. So dystrophin is a protein located between the sarcolemma and the outermost layer of the myofilaments in the muscle fibre, and it supports the muscle fibre strength, and therefore the absence of dystrophin causes reduced muscle stiffness and increases sarcolemma deformability. In other words, it compromises mechanical stability and connections to nearby myofibrils as well. Lastly, for this video we're going to take a look at cerebral palsy. So we have already covered this in the neuro block a while back, but it's really good to take a revisit to it because it's actually important to explore the symptoms in a bit more detail in a musculoskeletal manner. So just as a recap, cerebral palsy is a group of permanent disorders in the development of movement and posture. It is as a result of non-progressive lesion or injury to the developing brain, and it's got multiple causes or clinical manifestations. It is, however, a condition that progressively worsens over time, so it's a non-progressive lesion, but it does progressively worsen over time, the condition and the clinical findings. So the symptoms here are a mix of motor and sensory disturbances. So motor examples include spasticity, rigidity, ataxia, tremors, and aphatosis, so slow, writhing movements, delay in reaching milestones, and asymmetrical or wide-based gait. Sensory deformities include difficulty with vision and hearing, seizures, abnormal touch and pain perception, cognition changes, poor communication, and psychiatric conditions as well. The causes can be divided into prenatal, perinatal, and postnatal, with prenatal being by far the most common, including prematurity, inflammation, infection, toxins, and genetic syndromes, all contributing to the risk of developing cerebral palsy. There's also a link to periventricular leukomalacia, which is something that can be seen on scans, so that's softening of the white matter. So in exploring the symptoms of spasticity, this is hypertonia due to the upper motor neuron lesion. Dystonia is a movement disorder with sustained or intermittent contractions, and dyskinesia is either chorea, so jerking movements, or aphatoid movements, so slow and writhing movements. The complications of cerebral palsy include scoliosis, hip dislocations, torsion, joint contractures, malnutrition, osteoarthritis, and osteopenia, and it can be diagnosed through an MRI, a cranial ultrasound, EEG, and also clinical features as well. That's everything for this video. I hope you found it useful. If you do have any feedback, please do let me know, and thank you very much for listening.